Good evening, everyone. My name is Prarthna Bhardwaj. I'm a medical oncologist at Baystate. I have particular interest in breast cancer and familial cancer syndromes. Today, I'm going to be talking about precision medicine in breast cancer. And this is the third lecture in the breast wellness series that's being held as part of Breast Cancer Awareness Month. And hopefully some of you attended the talks on the importance of mammograms by Dr. Ajiba and surgical treatment of lumpectomy versus mastectomy by Dr. Casabon earlier this month. I do not have any conflicts of interest to disclose. Receiving a cancer diagnosis is a pretty emotional time that is often scary, confusing, and overwhelming, and it changes people's lives in many ways. And one of the change, I think, is really trying to learn some of the new terminology concerning your type of cancer, medical tests, the treatment options available. Oftentimes, physicians or healthcare providers are using medical jargon, and it may seem like, for patients and their families, it may seem like the medical team is speaking an entirely different language, using words and acronyms that you might have never heard before. And I think one of the terms that you may come across is precision medicine or personalized medicine. So what is precision medicine? It is basically an approach to diagnosis, treatment, and prevention that takes into account the genes that you're born with and the genes or other markers that are present within the cancer cells. Genes are basically information that tells the cells in your body how to grow and develop. And many cancers can affect or involve specific genes. Simply put, it's a shift from a one-size-fits approach to more of a tailored approach and more tailored treatment for you. Human DNA is approximately 99% similar across a population between, let's say, you and me. Yet, just like with zebras, the remaining 1% allows each of us to display our individual stripes. And the goal of personalized medicine is to really treat you. Again, personalized medicine is increasingly becoming a goal of healthcare. It is a medical model in which treatment decisions are based on each person's unique clinical presentation, meaning, what symptoms did they come with? What family history do they have? What are their labs and test results like? What is their physical examination like? And it also includes biomarkers or genetic makeup. And what that means is what kind of genetic alterations gave rise to your cancer, which we'll talk a little bit more in detail in subsequent slides. And of course, environmental information. And this involves environmental factors, lifestyle choices, your personal and cultural values. And the goal of personalized medicine really is to enable your healthcare providers to focus on the multiple factors that make you, you. And although it's not completely personalized where you're doing something very, very precisely, we've made significant improvements by certainly identifying subtypes of breast cancer. So how does precision medicine really help? It basically helps identify people who may have cancer susceptibility genes, meaning, do they have familial cancer, susceptibility to cancer because they have genetic alterations. It helps us to find certain types of cancers early. It helps us to diagnose a specific type of cancer accurately. It helps us choose treatment options. And it can also occasionally help us evaluate how well a treatment is working. Coming to breast cancer itself, it is the most frequently diagnosed cancer worldwide and among women in the United States. It's the second leading cause of cancer-related death among women, with lung cancer now being the number one cause among women. And 1 in 8 women will be diagnosed with breast cancer during their lifetime. In terms of, I'd like to talk a little bit about, the evolution of breast cancer treatment. I think, when this was first, identified, or rather early, many decades ago, previously, same treatment used to be given for everyone. And everyone with early stage breast cancer had some form of surgery followed by chemotherapy. And chemotherapy options were not plenty. There were probably 1 or 2 different types of chemotherapies that everyone got. And stage 4 or metastatic breast cancer cancer that has spread outside of the breast and the lymph nodes to multiple different organs were usually treated with chemotherapy again. And prognosis-wise, stage 4 cancers had very bad prognosis several years ago. Soon, doctors realized that this approach had different outcomes for women. Although everyone got the same treatment, not everyone responded the same way. This led to the question of why not? And the breast oncology community has constantly been trying to de-escalate unnecessary treatment or over-treatment, and also to spare patients the side effects of treatment that they may not benefit from. And this effort is, based on continued advances in our understanding of breast cancer, including that it's not just one disease, but that there are different types that can be targeted in ways that's tailored to each individual person. And we are honing our approach. We're now able to subtype different breast cancers. Again, now we understand what drives certain types of breast tumors. We know that one woman might need a certain type of surgery, as well as less chemotherapy or less radiation compared to another patient. And that knowledge has really changed everything for us. Coming to precision medicine in breast cancer, the hormone story is one of the earliest strides that we made in trying to personalize care. Around 80 to 85% of breast cancers express estrogen or hormone receptors, and breast cancers grow in response to their activation. So around 30 years ago, doctors showed that the growth of breast tumors that are estrogen receptor positive or hormone positive could be prevented or delayed by using treatments that are anti-estrogen, meaning you cut off the supply of the hormones that is activating the growth of cancer. Some of you might have heard of treatments like tamoxifen, or what we call as aromatase inhibitors like anastrozole, exemestane, letrozole, etc. These were really the first targeted drugs, what we call, in breast cancer, and potentially one of the earliest targeted drugs in any area of cancer medicine, I would say. I think, this was really one of the earlier, stories in terms of, how precision medicine in breast cancer started coming about. They also found non-hormonal drivers of tumor growth, and a particularly aggressive subtype of breast cancer has a gene abnormality that causes tumor cells to overexpress a gene called as HER2. So every normal cell also will have this HER2. However, about 15% of breast cancer cells seem to have excessive HER2. And this is something that was identified in the late 80s and early 90s, and they realized that too much of HER2 was helping cells grow and divide faster and resulting in more aggressive type of breast cancer. Here, I'd like to share the story of Barbara Bradfield. Barbara had fought early stage breast cancer and was in remission. In 1992, 2 years after she underwent a double mastectomy at the age of 48, she was found to have recurrence of her cancer. And when this was identified, this has spread to multiple areas in her body, including the lungs. She, instead of seeking additional treatment, was ready to go to Mexico on vacation and say goodbye, because in those days, a recurrence to multiple organs really meant that, prognosis was not good and that it resulted in poor outcomes. However, her oncologist decided to send her information to a physician in California who was working on understanding cancer genes, HER2 in particular. She got a call asking to be part of a small clinical trial for a potential new medicine. And she went ahead with it as she felt she had nothing to lose at that point of time. She became one of the first women in the world to receive a medicine that's now come to be known as Herceptin or trastuzumab. And this is a medicine that specifically targets this HER2 gene and shuts it off. Thus, it's kind of preventing cells from growing and dividing. And the theory is that it would help curb the growth of cancer. Eventually, 900 very brave women, volunteered and went on to receive this treatment over a period of 6 years. And I think, they risked receiving this treatment and what time they had left, because this was unproven treatment at that point of time. And interestingly, Barbara Bradfield is still alive today, and she's one of the 15 women who participated in the first phase of the trial over almost 30 years ago now. It's not a typical outcome for this type of cancer. However, I think, her story has become a beacon of hope for women who have breast cancer, and it shows us really, us as a community, that targeted medicines can work. And, this started forming the second crux of precision medicine in breast cancer. So now every breast cancer is tested for hormone receptors and HER2 receptors, and this is referred to as molecular subtype of breast cancer. So should somebody receive a diagnosis of breast cancer, you will also receive information from your medical team with regards to whether this is hormone receptor positive or negative, and if it's HER2 positive or negative. The most common type of breast cancer tends to be hormone receptor positive and HER2 negative, and this is about 80 to 85% of women. Again, all of this information is really useful information for us in both early stages of breast cancer as well as later stages of breast cancer for treatment purposes. Now, what is cancer? Cancer is basically unregulated or uncontrolled growth of normal cells. And this occurs due to genetic or genomic alterations in the body. These are also known as mutations, which is what I'm going to be referring to for the rest of the talk as well. Now, it's, I want to kind of simplify, how genomic alterations cause cancer, because that helps us understand, how are treatments being developed, which forms really the basis of precision medicine from a biomarker perspective. So there are really three types of genes that are quite important in this aspect. One is called as the proto-oncogenes. So really, proto-oncogenes are normal genes that help the cell to divide and grow. They basically regulate cell growth. Sometimes they can become defective. There are genetic alterations or mutations that occur, and it gives rise to uncontrolled cell growth. The way I like to think about it is it's like pushing on the gas pedal. It acts as an accelerator. You have a gene that's telling the cell, go, 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 and it's kind of driving it towards cancer. HER2 is actually this type of gene. However, if there are genes that kind of can accelerate cell division, there are also genes called as tumor suppressor genes that act like a stop or a brake pedal, meaning that they turn off cell growth. So, there are things in place in our body which can kind of curb any acceleration that is happening. However, if tumor suppressor genes are absent or they're mutated and they're not functioning the way they're supposed to, the normal brake mechanism gets disabled, and this once again results in cancer. And the third type of gene is called as a DNA repair gene. So basically, DNA repair genes can help correct any errors that occur when cells duplicate their DNA in preparation for cell division. And if any alterations occur in this gene, or if they're defective, then they're really not able to repair any kind of errors that occur. And so the accumulation of errors can kind of overwhelm the cell and result in cancer. And an example of this is the BRCA gene, or the BRCA gene, which some of you might have heard of. We discussed how cancers occur through genetic alterations. I want to just switch gears a bit and see if anyone know what is common to both these people, other than the fact that they're both, of course, actors. Since this is a webinar and not an interactive Zoom session, I'll go ahead and tell you. Both of them were diagnosed with carrying the BRCA gene, which increases people's risk of developing breast cancer. So again, these genetic alterations that we're talking about can be of two types. They can either be hereditary, meaning that you're born with it, or it can be acquired. It's also called as somatic. Now, hereditary mutations tend to run in families. This is something an individual is born with. They're also called as cancer susceptibility genes. People with these genes have a higher risk of developing breast cancer and potentially other specific types of cancers based on the type of gene that they have. It can be detected with a blood test. However, not everyone qualifies for genetic testing. There are very specific indications for who qualifies, as there's only a 5 to 10% chance of identifying these genes among people with breast cancer. And it's important for the right person to get this test, as it has implications on treatment as well as how we monitor breast cancer once somebody is in remission. Some examples of these mutations include BRCA mutations, PALB2, ATM, SHEC2, etc. Now, acquired or somatic mutations, like we spoke about the hereditary mutations. However, most cancers that people develop really occurs because they've acquired some mutation during their lifetime. It could be environmental factors like smoking or alcohol use. It could be hormonal factors. And there are other cancers where certain types of viruses can increase your risk of other types of cancers, not breast cancer, but other types of cancers. And now what we're able to do is we can sequence a person's DNA to identify these mutations. So there is availability of something called as next generation sequencing that can help determine what kind of mutations are implicated in a particular individual's cancer. And certain mutations do have targeted treatments available against them, which we're starting to use. This again is also precision medicine, meaning we're identifying what mutations your tumor has and trying to see if there are treatments available against that type of mutation. Keep in mind that when somebody undergoes this next generation sequencing test, probably they're tested for about 80 to 100 genes, depending upon the type of testing that is done. There are different vendors, and depending upon where you get your treatment, different types of tests are used. However, the basic principle of it is that they're trying to sequence your DNA to see what kind of mutations you have. So they are testing you for about 80 to 100 mutations, but we do not have treatments for all of them. We probably have treatments for a handful of them at this point of time. But it's work in progress. There are a lot of studies and clinical trials and drug development that's happening to see, are there certain mutations that can be targeted. Now, there are some examples of mutations that do have treatment options, called as the PIK3CA mutation or the ESR1 mutation, AKT mutation, etc. How do we test for these genetic alterations, you might ask? What do I need to do? Do I need to give blood? Do I need to get a biopsy? How are we going to test for this? So really, there are two ways of doing it. You can get tissue from the biopsy that one undergoes, and you can send that for testing, or you can undergo testing from blood. Now, for hereditary conditions or hereditary gene mutations, we typically do a blood test because blood is where your DNA is floating around, and that's what we're able to sequence. In terms of trying to identify the genetic personality of your tumor or those acquired mutations that we were talking about, it's best if we get it from the tissue itself, because that's where you have the maximum number of DNA cells and DNA that you can really kind of sequence. However, if there's not adequate tissue, in certain situations, trying to get blood might be appropriate, because there are DNA from tumor cells that are also floating around in blood, and we might be able to pick it up. However, we would recommend tissue ahead of blood if possible for testing for any acquired type of mutations. These terms used by doctors in terms of this testing, they're also called as molecular tests, genetic or genomic assays, tests to assess the personality of your tumor, or biomarker testing or next generation sequencing. So these are all one and the same, which is either testing of your tissue or testing of the blood that can be done. So targeted treatment, which is again part of precision medicine, is identifying a specific target or genetic mutation and finding a treatment or a drug that acts against it. Typically, these are, have most frequently been approved for stage 4 or advanced breast cancers. So most of the time when people are undergoing these tests that we spoke about, where they're doing genetic testing, for the tumor itself, it's typically done for people with stage 4 cancers. However, the typical course that follows is that if good success is seen in people who have stage 4 cancers, clinical trials and experiments are run to see if the same success can be replicated or duplicated in early stage cancers. And not everyone qualifies for all of the treatments, so it's really important to discuss this with your treating oncologist. And as I mentioned, not every mutation has a treatment that is available for it. Now we might ask, how is this helpful? What does this really mean in terms of targeted therapy? Targeted treatments have in many instances gained approval prior to use of certain chemotherapy, which means that it essentially allows people to omit or even delay chemotherapy and may be more tolerable. Lesser side effects, fewer side effects. In several cases, it might be a pill medication or an oral medication instead of an IV medication. All of these options are most importantly allowing women to live longer and without progression of their cancer quickly. So I would certainly say that, the paradigm of how we're treating breast cancer is changing quite rapidly. There are so many clinical trials that are happening at this point of time. And what is probably current standard of treatment may not be the same in like a year or a year and a half, sometimes even 6 months. So it's really important for you to discuss all of this with your treating physician, and it's important for all of you to understand that. Another thing that we get asked about is, hey, doctor, am I eligible for immunotherapy? Can I get immunotherapy? What is immunotherapy? It is a type of treatment that boosts your own immune system to fight cancerous cells. They do not directly kill the cancer cells themselves, but it boosts your immune system to fight cancer cells. All of us are born with the ability to be able to fight cancer cells through our immune system. For some reason, in people who do develop cancer, this switch is turned off. So giving immunotherapy kind of boosts the immune system once again to try and fight cancer cells. Not everyone, again, is eligible for these treatments. There are certain types of cancers called as triple negative breast cancer, meaning they don't have hormone receptors or HER2 receptors that is accelerating the growth of cancer. It's something else that's causing cancer. That's triple negative breast cancer. And these tend to be very immunologically active cancers. And so for such cancers, immunotherapy would be very appropriate. And also when we send out for the DNA sequencing that I was talking about, it also gives us information on something called as a tumor mutational burden, meaning how quickly or how rapidly is your tumor dividing. And people who have a high tumor mutational burden, they've done studies to show that immunotherapy seems to be pretty effective for them. And of course, as part of clinical trials, certain people are receiving immunotherapy even with other indications. So in summary, although, personalized medicine or precision medicine holds great promise and can make cancer treatment more effective with fewer side effects, there are still associated challenges that are not quite limited to the science behind it. There are several public policy and ethical challenges that exist. They need to be addressed in order to, fulfill patient needs very safely and effectively. Some of the challenges include, as I mentioned, personalized treatment is not available for all types and subtypes of cancer. Some personalized treatments or precision targeted treatments are only available in clinical trials. Genetic testing can be expensive. Frequently, insurance plans do not always pay for it. I think, for the tumor testing now, if the indication is appropriate, again, insurance pays for it. But because this is DNA sequencing, it takes some time. It takes at least 10 to 14 days sometimes for us to get back the results, meaning that you have to wait a bit longer to get these personalized treatments if you're a candidate for it. And of course, with all these new fancy medications that are coming into play, these are expensive treatments, and that is something that certainly needs to be kept in mind before we proceed with treatment as well. And patients may also need to consider a couple of things that should they have a genetic-based test to determine the possibility of benefiting from a certain type of targeted therapy. If they're diagnosed with a cancer associated with an inherited genetic mutation or something that runs in families like the BRCA1 or 2, like the BRCA gene that we spoke about, should family members be receiving genetic testing to help determine their risk? Should patients agree to donate their tissue for research? Because, that's how science is progressing. So, there are all these questions that come up, and it's important for, people to understand that, these have implications not only for them, but also for their family members. So what should you be asking your doctor, if you have breast cancer, is what type of breast cancer do I have? Is it hormone positive? Is it HER2 positive? Do I qualify for genetic testing for hereditary cancer susceptibility genes? Do I qualify for special tumor testing for new treatments? These are some of the questions that you want to ask your treating doctor. For more information, I would suggest that you look up these websites, cancer.net. This is a very patient-friendly website that is catered for people who have a diagnosis of cancer. And this is run by the American Society of Clinical Oncology, which is our society and the guidelines that we follow. There's also the National Cancer Institute website. And if you're interested in learning a little bit more about the HER2 story by GeneTech, just on Google type out GeneTech HER2 story and you'll get it. It's actually a pretty fascinating story in terms of how treatments for HER2 positive breast cancers have evolved over time, and it's actually quite inspiring in terms of the strides that have been made in the world of breast cancer over the last few years. And I would like to conclude by saying that here at Baystate, we're fortunate to have a great team of medical and radiation oncologists, as well as breast surgeons, who come up with a tailored plan for you. We're constantly communicating with each other. And so, don't hesitate to ask us questions to understand what your treatment options are and why a certain type of treatment is being recommended to you. And with that, I would like to open up further for questions.
Awesome. Thank you, Dr. Bhardwaj. I wonder when that picture was taken when there were no cars in the parking lot.
Probably when it was built very initially.
Yeah, obviously before we were open. I thought that slide about what questions to ask your provider were fantastic. That was great. That was a great slide, as well as the other ones too. But thank you for that great talk. There are some questions in the queue. So if you don't mind, I'm going to get right into it. The first one is, did I understand correctly that the BRCA gene is a DNA repair gene?
Yes, BRCA gene is a DNA repair gene, yes.
Excellent, thank you. The next question, is there ongoing research on why the HER plus protein cause breast cancer?
Yeah, I think, there's constant research that is happening. So if you think about it, HER2 is present even in normal cells. It helps the cell divide and grow. For whatever reason, again, it could be genetic mutations, alterations that we're talking about. Certain types of breast cancer tend to overexpress HER2. They have 20 million HER2 instead of 200 HER2 receptors, which means that 20 million receptors are working rather than 200 receptors. So they're very efficient in making the cells grow faster and divide more. And so that results in cancer. Now, environmental factors, hormonal factors, different things can kind of make a cancer overexpress HER2.
Excellent. Thank you. As a side note to that, that person has stage 2 breast cancer and had their first baby.
I'm sorry, can you repeat the question? I didn't get the question.
No, I'm just saying that the person who asked that question just has stage 2 breast cancer and just had their first baby.
Wow, okay.
The next question is for triple.
I'm sorry, Sue, to cut you off, but I think it's not uncommon for us to see pregnant or postpartum women be diagnosed with breast cancers. I think it's so important for us to be able to tailor treatment for these people, mainly because not all treatment is safe for their babies, and so your healthcare team might come up with a plan that is not the same that is done for somebody who's not pregnant or somebody who's not postpartum. So that's something to keep in mind as well.
Yeah, excellent. And part of that precision medicine as well, right? The next question is, this person has triple negative breast cancer. What determines that treatment? And is it all the same for triple negative?
Yeah, great question. So again, when, like I was saying, like precision medicine isn't that precise yet. I think, we've been able to subclassify breast cancer into triple negative, HER2 positive, and hormone receptor positive cancers. So for stage 1 triple negative breast cancer, it is a specific treatment. For stage 2, it's a specific type of treatment. Stage 3 is another type of treatment, and stage 4 is another type of treatment. Typically, for most people, it's the same kind of treatment that is available. For stage 4 triple negative breast cancer, again, it's a little bit more unique because we send out some of these tests that I spoke about. And so depending upon what we see, the sequence of treatments may be a little bit different. So someone might be a candidate for immunotherapy, whereas someone might not be a candidate for immunotherapy. Someone might need chemotherapy up front, but someone else might not need that. So I think, specifically for stage 4, it's based on what we find. However, for the earlier stages, usually it's uniform. Now, there are different types of chemotherapy options that are available for the early stage triple negative breast cancers. And typically for triple negative breast cancers, chemotherapy is recommended no matter what the stage is, even if you're diagnosed at stage 1, unless it's like a minuscule tumor. Pretty much even stage 1s get, anybody with stage 1 breast cancer also gets chemotherapy. What type of chemotherapy you get is usually standard. However, depending upon what your medical conditions are, etc., we may have to tailor that. So again, we take into context your medical history, what your kidney function looks like, what your liver function looks like, and then we make those treatment decisions.
Excellent. Thank you. The next question, is there a benefit to repeat a blood test such as a 360 for mutations that may develop later?
Wonderful question. Yes, there are certain scenarios or situations where it would be appropriate to repeat testing. Cancers are really smart. They identify and find ways in which they can not respond to the treatments that we're giving them. They develop or acquire more mutations along the course in order to make sure that the treatment that we're giving loses its effectiveness. So it's effective for a period of time, and that's the reason why people can have progression of their cancer despite the treatment that we're giving. So we don't typically repeat testing in every scenario, but there might be certain situations where we do recommend repeat testing.
Excellent. Thank you. Next question. How far away are we from having mutation testing being a standard part of normal healthcare, not done only when cancer detected?
Yeah, I think, this is really tricky because not everyone who develops mutations develop cancer. However, people who have cancer have certain types of mutations. So we have to really weigh the risks and benefits of doing a test, because if you identify a mutation, the question is, what are you going to do with that information? Um, so there's going to be over testing, over treatment, over more scans, more tests, and more anxiety, really. Um, this is a little bit different for somebody who is being tested for a cancer susceptibility gene that runs in the family, because these mutations increase your risk of cancer, and we know that there are certain mutations that certainly increase the risk of cancer, and those we want to identify. So again, we have specific criteria for who would qualify for this testing. And if you qualify, yes, we want that information so that we can plan for you to ensure that your risk of cancer comes down with heightened, monitoring or with treatments, etc. But in the absence of you qualifying for a test like this, typically just routinely, we don't just check for mutations.
Thank you.
I think part of who qualifies for that depends on what your family history is mainly. Like, do you have multiple members in your family who have breast cancer, who have ovarian cancer, uterine cancer? Interestingly enough, people of Ashkenazi Jewish ancestry are actually at a higher risk of having certain types of genes like the BRCA genes. So a lot of those people qualify for genetic testing automatically. So you might get asked at your visit often what your ethnicity is. So, in today's world, I think, it can make people a little uncomfortable, but there's a specific reason why we're asking you these questions.
That's good to know. Thank you. The next question, is it likely that patients will need to go to other different facilities for different treatments?
I think it depends on where you're getting treated. Here at Baystate, we have our radiation oncologists, our surgeons, and medical oncologists working in, all together. So all of the treatments that we provide usually is done here at Baystate. Sometimes, we may refer you to a higher, to another center, like maybe Dana-Farber, if there's a clinical trial which we think you might benefit from that is not available here at Baystate. But really, other than that, it depends. Like, not every program has all the care coordinated. But from our perspective, usually, if it's something that we don't provide here, that's when we would be referring you elsewhere. Otherwise, all the treatment happens here in Baystate.
Thank you. The next question will this seminar be available on the Baystate Health website to watch again? Yes. I believe it'll be baystatehealth.org/breast series. We'll be putting all 3 recordings on the site. So thank you for the question. Are there ever instances when more than one type of breast cancer present at the same time in the same breast?
Yes, it can happen. Again, those are trickier. We don't often see them. However, absolutely, we do see them where you can have one tumor that is HER2 positive and another tumor that's HER2 negative. We have to treat for both. And usually, the HER2 positive is something, I'm giving you an example. So the HER2 positive is something that tends to be a little bit more aggressive and certainly needs that treatment. But yes, those situations arise where, you have a tumor, 2 different types of tumor in the same breast at the same time.
Thank you. Which breast cancer has the highest recurrence, and is treatment the same?
So many different types of breast cancer. I think in terms of recurrences, they're all a little bit different. So triple negative breast cancer, which is cancers that are not driven by hormones or HER2 tend to usually be the more aggressive types of cancers. They tend to occur in younger women typically, and their risk of recurrence is pretty high. But their risk of recurrence usually is highest within the first 2 to 5 years, not so much after. However, hormone receptor positive breast cancers, their risk of recurrence compared to these other types of cancer may be lower. However, the recurrences can occur much later on, like 20 years later, 25 years later. We've certainly seen it. So I think it's a little bit different for each type. And this is, and these are, questions that you want to ask in terms of, when, am I at a risk for recurrence? When can I expect recurrence? What is the likelihood of a recurrence, etc.
Thank you. Which breast, sorry. I just asked that one. When you get, if you get an allergic reaction to chemo, what would you do next?
I think it's important for us to, I think it's a sort of a general question. I'm going to try my best to answer it. So it really depends. It depends on how severe the allergy is. Is it life-threatening or not? Have we identified a reason for why you developed that kind of an allergy? Because there are certain types of treatments, certain types of chemotherapy. The vehicle in which the chemotherapy is given is what may cause the allergy. So we may be able to use a sister form of the medication, which might not cause that allergy, for example. So it really depends. If it's something that's life-threatening, usually we do not re-challenge. We don't want to take that risk unless, we have no other option, in which case there might be some desensitization protocols that we may use to make sure that, people get sensitized to it and that allergic reaction doesn't occur. But I think it really depends.
Can you develop breast cancer again after a full mastectomy?
Yeah, so you can. So when recurrences of breast cancer occur, breast cancer might come back either in the same breast, the opposite breast, or elsewhere, like, different organs. Like the bone is the most common organ that breast cancer tends to go to. So having a mastectomy can help prevent local recurrence, meaning recurrence in that particular breast. If you've had a double mastectomy, you're less likely to develop cancer in the affected breast and the opposite breast. However, it doesn't prevent you from developing breast cancer in the bones, which is why there is always a chance of recurrence at some point of time, potential chance of recurrence at some point of time, and which is why you're monitored and you're seeing, healthcare professionals for monitoring.
Thank you. There are some questions about who to contact for a visit, and I'm just looking on the website. There's a number of phone numbers, but if you're in the Springfield area, there is the Baystate Breast and Wellness Center. It's 794-8899. And Dr. Bhardwaj, did you have a slide with contact information on your presentation?
I did not, but I can type it out.
That's a really nice picture.
I know I can type it out really quick.
No, it's good.
Yeah.
So, if you go to baystatehealth.org/breast-care, you'll be able to get information at Baystate. Oh, and then yes, they wanted this last slide with the to find more information. Thank you. That was what we needed. I believe that is all the questions. We'll just give it another minute. It looks like that's it.
Yeah, I actually just saw a couple of comments about
Good.
A person being sent to Beth Israel Deaconess from Baystate for a total lymph node removal. That is a special kind of a procedure called as, a mapping procedure that they kind of do. They're not currently doing that at Baystate, which is why a breast surgeon might refer a person to a different center. And I also see a comment regarding somebody who was diagnosed with triple positive at the start, who's had stage 4 cancer for over 9 years and then flipped to HER2 negative. Yes, cancers have the ability to morph or shift or change, and which is why, oftentimes you may have to repeat a biopsy to make sure that you have the same type of cancer, because if you flip in terms of the HER2 status, for example, the treatment against HER2 might not be effective. So there are situations where, if you were to develop, a recurrence for the first time, you will certainly be asked to biopsy that particular tumor, and that may be repeated again in the future too at some point of time during the course of your treatment.
And thank you. There's one more. Can you comment on ILC and methods of watching for recurrence?
So ILC is invasive lobular cancer. So when you think about breast cancer, the breast is basically made up of milk ducts that empty out into the nipple, and at the end of the milk ducts are milk sacs. So cancer can occur either in the ducts or in the milk sac. Now, if they occur in the ducts, it's called as invasive ductal cancer. And if it occurs in the milk sac, which is also known as the lobules, it's invasive lobular cancer. Invasive lobular cancer is a little bit unique in the sense that they don't always get picked up very clearly on mammograms, which is why, when we look at the mammogram, we look at the entire report of the mammogram, which tells us, is there a possibility that something is getting obscured? So at this point of time, we still recommend only a mammogram for invasive lobular cancers, but there might be certain situations where we may recommend doing an MRI to watch for recurrence. Those, again, are very specific situations. We don't usually recommend it to everyone because MRIs can pick up a lot of false positives. So again, for any early stage breast cancer, we still recommend simply a mammogram. We do not recommend CAT scans to see if it's coming back, outside of the breast, unless somebody were to have symptoms.
Well, all questions have been answered. It was a great presentation. And I want to thank our attendees for all those great questions. And I want to thank you, Dr. Bhardwaj, for the great presentation and sharing your expertise with us tonight.
Thank you for having me. And, we have a great team here. And if anybody has questions, they can certainly feel free to reach out to us. And we're happy to help.